My name is Andrew Chou. I'm a health service researcher and emergency physician from the Brigham and Women's Hospital. Along with my co-authors, I thank you for your interest in our project, in which we examine the effect of Medicaid expansion on the reasons for emergency department use among the low-income population. The project was supported in part by Massachusetts College of Emergency Physicians Fellow Research Grant. We otherwise have no other disclosures relevant to the project. Medicaid expansion was a signature provision under the Affordable Care Act that was signed into law in 2010. However, its constitutionality was challenged in 2012 in Supreme Court ruling, which deemed that the states may opt in of Medicaid expansion if they so choose. How Medicaid expansion influences EDUs among low-income population has been an area of controversy. The intense interest is largely fueled by the finding that low-income population disproportionately use emergency departments for acute unscheduled care. However, to date, numerous studies have examined this and have found conflicting findings from study to study. The objective of our study is to examine the reasons for EDUs among low-income adults and how Medicaid expansion may have influenced those reasons. Prior studies have examined overall utilization without really differentiating different reasons patients seek emergency care. Through our study, we hope to provide a deeper understanding of how Medicaid will impact emergency department use among the lower income population. We use data from the National Health Interview Survey, which is an annual survey conducted by the National Center for Health Statistics. We included adults aged 19 to 64 years old who reported a total family income below 138% of federal poverty level. This is consistent with the Medicaid eligibility criteria for expansion states. We chose these data years as during these years the survey included questions that asked respondents who reported EDUs the reasons for their EDU visits. The main outcome measure is the proportion of respondents reporting ED visits within the past 12 months. We further categorize these ED users by the reasons for their ED visit into three mutually exclusive groups using a hierarchy. First category included respondents that reported ED visit due to perceived high illness severity, such as feeling they're too sick for the office or feeling that they can only go to the hospital and only a hospital can help. The second group of ED users included those that did not report any of the reasons for perceived illness severity, but reported that they went to the ED because the office was not open or unavailable, such as they're closed during off hours or during the weekends. The third group of ED users reported none of the above reasons that we mentioned already, but did report ED visit due to barriers to outpatient alternatives, such as feeling that there's nowhere else to go, or usually goes to the ED for care. We implemented a difference in differences analysis to compare the changes over time between expansion states versus non-expansion states. The survey has a 12-month look-back period in which, in the form of asking a question, in the past 12 months, have you went to the ED to be evaluated? Therefore, we defined the first year after Medicaid expansion to be a transitional year, which is 2014 for most expansion states and all non-expansion states. We defined the post-expansion period, therefore starting the second year and onwards after Medicaid expansion was implemented, or 2015 to 2017 for most expansion states, and again for all non-expansion states. We use survey-weighted linear regression with state-level clustering to calculate the difference in differences estimates for each outcome. When we examine annual outcomes, we found that overall EDUs, as well as EDUs due to perceived illness severity and office closure, did not have any clear divergent trends before and after expansion. However, EDUs due to outpatient access barriers seem to have a diverging trend with a decrease among the expansion states after Medicaid expansion. In adjusted analysis, we found that Medicaid expansion was not associated with any significant changes in the overall EDUs or EDUs due to perceived severity for office not open, but it was associated with a significant decrease in EDUs due to access barriers. As a secondary analysis, we further divided the expansion states by whether or not they require additional copayment for potentially non-emergent or non-urgent ED visits, which is a common policy in many states. We found that the effect of Medicaid expansion on EDUs due to access barriers was mostly in states that did not require copayment for non-emergent ED visits. To summarize, in this national study, we found that Medicaid expansion was not associated with significant changes in the overall emergency department use. We believe this is likely because most ED users report reasons that were really not modifiable through coverage expansions, such as perceived illness severity and office availability. However, Medicaid expansion did decrease respondents that reported EDUs due to outpatient access barriers. This is very consistent with a plethora of studies examining Medicaid expansion showing improved outpatient access. We did find that this effect is predominantly among expansion states that did not require copayments for non-emergent EDUs. The underlying mechanism still remains unclear and requires further research. We hypothesize that this is because these states also did not require significant out-of-pocket costs for the copayment for outpatient services, and therefore able to reap the benefit of Medicaid expansion. Thank you for your attention. I hope you are all staying safe during this challenging time, and we welcome any comments or suggestions.